This is Dr. Cecily Havert, once again, Northern Virginia Family Practice. This is the special town hall virtual series that we've been having for the last couple of years. We're happy that we're doing this on a monthly basis now, and happy for those of you who are joining us this evening. We have a very, very special presentation tonight. I'm really excited about this. We actually have a presenter, but we also have a special guest. And first of all, I'd like to introduce Dr. Yasmin Banaei. She is our presenter this evening. She's a psychiatrist in private practice in Washington, D.C., with a subspecialization in reproductive mental health, which is a focus in the treatment of women who experience emotional or physical difficulties during their reproductive life cycle. Dr. Banaei received her bachelor's degree and her medical degree from the University of Virginia, after which time she moved to Washington, D.C. to complete her residency in psychiatry at Georgetown University Hospital, where she served also as chief resident. She has also received training in mindfulness-based stress reduction therapy and is a registered yoga instructor. So Dr. Banaei is going to be giving us a presentation on perinatal mood disorders. But before we get started with that, I do want to welcome both Dr. Banaei, but also our special guest this evening. I'm going to introduce Dr. Abbas Shaberi. Dr. Abbas Shaberi is a gynecologic surgeon, board certified in female pelvic medicine and reconstructive surgery at Innova Health System. He is also a very talented artist who has a powerful exhibit right now in the DuPont Underground Gallery in Washington, D.C. Dr. Banaei and I actually attended a tour that he gave this past weekend at the gallery, which shows how compassion and medicine intersect through the visual images of grief, pain, loss, and healing. Dr. Shaberi, can you tell us a little bit about the art that you've created that's moved so many of us? Dr. Banaei and I just were in awe the whole time that we were at your at the exhibit that you have in DC.
Yeah, first of all, thank you so much for inviting me. I'm very happy to be here. The exhibition, really a product of probably 30 years of observation on what women go through after delivering their babies. And really the exhibition represents emotions that are not commonly associated with childbirth and delivery. And what the exhibition does, it takes women through various stages of mental health issues and recovery and healing.
So, yeah, no, and what Dr. Banaei and I were so, taken aback, and Dr. Banaei actually has incorporated a lot of the images of your art in the presentation. So it's an honor to have you here, just to, have the actual artist with us here today, because I think your art actually is going to add a lot to the presentation. So thank you so much for being here. And without further ado, we're going to go ahead and get started with Dr. Banaei. We feel free to put questions in either the chat or the Q&A, but we're going to probably leave most of the Q&A until the very end. So why don't we go and get started? Dr. Banaei, thank you so much for being here.
Oh, thank you for having me. I'm very excited about this. Are you able to see my shared screen?
Yes, it looks great.
Okay, super. So I'm going to get started. I am just delighted to be speaking today about what is probably my favorite professional topic and a top favorite personal topic, which is maternal mental health. You will hear me use the acronym PMADs a lot today, and PMADs stands for perinatal mood and anxiety disorders. It is a catch-all phrase for the emotional complications that can happen both during pregnancy and after birth. And it spans the gamut from depression, anxiety, trauma responses, OCD, bipolar spectrum disorder, and even postpartum psychosis. These are all temporary conditions if they are treated. And what we find over and over again is that they don't discriminate against who they can afflict. So it can be surprising for some people when they get it. PMADs are the #1 health complication postpartum. More women suffer from them than from preeclampsia, postpartum hemorrhage, postpartum infection, and gestational diabetes combined. And if we just take a minute and think about the level of obstetric care that goes around monitoring and preventing a lot of these common medical complications of pregnancy in the postpartum period, and put that into context of how common PMADs are in comparison, and sadly, how little screening and support the emotional health of mothers take or get in pregnancy, it really highlights a gap in our medical care system. To bring this a little bit kind of to the individual level, the prevalence of PMADs is that 1 out of 5 new mothers will suffer from something from the span of PMADs. So if you think about that a little bit, kind of, putting faces to these statistics, you have a mom. You may be lucky to have known maybe one or both of your grandmothers. I'm a mother, so there's 4. And I bet you know at least one other person who's a mom. So statistically, 1 out of these 5 people who who are mothers are likely to struggle or suffer from a perinatal mood and anxiety disorder. This number is even higher in certain vulnerable populations who carry certain risk factors. And I'll go over these in a little more detail a couple of slides down, but this number is about 1 out of 3. So why do we have such a high rate of PMADs, especially in our country? This is complicated, and it has a couple of different systems that come into play. At the individual level, so at the level of the person, we have vulnerabilities that are conferred biologically, like from our genetics and from epigenetics, and psychologically, like from our life experiences and our childhood, and maybe from some of our temperamental dispositions. And this person, with her internal stuff, lives in a context. There's a social milieu, there are certain cultural ethos, there's a political system, and these are the macro factors that shape what happens inside a mother. She's informed by these external norms, she's in dialogue with the environment. So it's not just the person, it's the person within and in response to a system. At the individual level, there are certain features that increase that person's risk for PMADs. Probably the biggest predictor for a PMAD is someone with a personal history of any mood and anxiety disorder. And this does not have to be within a pregnancy or postpartum period in the past. It can be any over the course of their lifetime. And of course, a family history is an additional predictor. Anyone with a history of trauma, type A women with perfectionistic tendencies are at risk. Anyone who had a pregnancy that was either unplanned, unwanted, or was complicated medically is at higher risk. Any state that raises the baseline level of stress, so women of color, those with marginalized identities, they suffer from something called minority stress. Those who live in poverty or with financial insecurity, anyone with recent big changes in their life, like a job change or a family member who has been diagnosed with a significant medical illness or, having a big move. Relational strain, and this can be with one's partner or really with anyone that the mother interacts with and relies on a regular daily basis. And children who have high needs, either medically or temperamentally, put the mothers at higher risk. In addition to these individual risk factors, there are also phase of life risk factors that are unique to the perinatal period. These open additional vulnerabilities, again, at the individual level. So some of these factors would be the physiological changes that come with pregnancy, with birth, with breastfeeding. These are some seismic hormonal changes that happen in a woman's body and can have repercussions emotionally. Pain is always a risk factor for mood issues. So experiences of pain, either from pregnancy or delivery or postpartum, and especially physical trauma, which of course can be related to delivery, but pregnancy itself can have some repercussions, and breastfeeding can have some physical trauma as well, are risk factors. And something that's unique to this stage is the enormous shift in the identity of parents that takes place. People who, previously were childless are suddenly responsible for keeping a fragile human alive. And with this comes new skills, new disagreements, new negotiations, and just generally new dynamics within the family unit. And this unit has to learn all these new things in the setting of very little sleep. Because anybody who's had a child knows that newborns are not predictable and they do not sleep in consolidated stretches of time. And so often the gap between how mothers thought that new motherhood would be like for them and how it actually goes becomes quite a significant risk factor for PMADs. And this last bullet point ties in with the cultural context, the macro pieces. In our culture, there is a dominant programming that seems to suggest that motherhood, and specifically a particular kind of motherhood, is the primary path to fulfillment for women. And it promises that when a mom is able to meet the needs of her family, then she will feel complete. Baked into this kind of motherhood programming is also an idealized representation of the mother, that the good mother is self-sacrificing and the good mother has no needs other than those of her family. Let's take a look at what I conceptualize as two culturally dominant archetypes of this good mother. The first is the natural nurturer. This is a mother who is intuitively maternal. She really doesn't even need to learn how to be a mother because she is expected to be gifted with the intuition on how to care for her child from the moment he or she is born. And from her baby to her husband, to her partner, to her thriving plants in her home, she is just naturally able to nurture life to grow. She is never angry. She maintains a tidy house. She takes up very little space, both in physique and in her wishes and her desires. She just generally knows how to keep people happy. The second archetype is the supermom. And this photo of Giselle, the supermodel, here being depicted as supermom, is probably one of my favorites that I include in almost every talk I give on maternal mental health. Supermom is a superhuman who can do it all. She works a high-powered job. She is sexy, but modest. She shows up for work as she breastfeeds her infant. She doesn't need much rest, and she makes all that she carries appear effortless. She is strong, she doesn't complain, and she is heroic. So she does it all, and she does it alone. In part because she believes that's what a good mother should do, but also because she has no other choice. At the structural level in our country, the supports for a mother are frankly abysmal. The US is the only industrialized nation that does not offer paid family leave. For mothers to have paid family leave or paid maternity leave, they have to use a combination of short-term disability and of their banked up paid time off. Childcare and healthcare, two services that in many developed countries are considered universal rights, are private industries in the US. And to access them is costly, but to access higher quality childcare and higher quality healthcare is enormously costly. And as our public policies kind of deprioritize the needs and supports for a mom, And at the same time, as we see the rise of what is considered the nuclear family and with technological advances over the probably the last 50 to 100 years, the village, the kind of traditional village of the human community that used to catch the gaps in public policy has also dissolved. And so in this way, we live and breathe in a cultural ethos of rugged individualism. This is a really interesting study. It's probably one of my favorite ones that I've come across recently, that studies rates of parental burnout across 42 countries. And it has found a very strong trend between parental burnout and countries and cultures that carry more individualistic values as opposed to community-based ones. So let me orient you to this graph. On the x-axis, you're seeing a measure of individualism, and as it moves higher, it's higher rates of individualistic culture. And on the y-axis, you see the levels of parental burnout. And so the higher it goes, the higher the burnout levels are. And what I've circled for you is where the US falls. And the US tops the charts when it comes to parental burnout. And one really interesting analysis from the study was that the authors found cultural individualism plays a larger role in predicting parental burnout than economic inequalities, the number and age of children in a family unit, and how much time a parent spent on caretaking, which I just find just all levels of fascinating. So when we couple the person's risk factors at the individual levels with motherhood norms that are set impossibly high, alongside a cultural ethos of individualism within the setting of what I would consider a betrayal of structural supports, then emotional challenges flourish. I have prepared a case for you. It's not an actual patient. The names are not real. I've made it up, but it very easily could be. And I have probably seen the equivalent of 6 Lydias in my practice just this week. So Lydia is a 34-year-old lawyer. She's presenting to us at 7 weeks postpartum. This is her first child, but it was from a second pregnancy. Her first pregnancy was a termination, an elective termination about 7 years ago. And here is Lydia's story. My son Felix was born at 35 weeks because my blood pressure was high. He had to spend 2 days in the NICU. I felt disconnected from him from the beginning. I have not felt like myself since Felix was born. I have struggled with breast milk supply. Last week, at his pediatrician's visit, there was so much commotion about how little weight he has put on. He has fallen off his growth curve. Of course, I panic. I've been starving him. I am ruining my baby's life already. My partner returned to work 2 weeks after Felix was born. Taking care of Felix has taken over my life. I thought I would be a mom who would go on walks every morning in coordinated outfits. In reality, I've been stuck in the house. My house is a disaster. I feel overwhelmed all the time. When I do have a moment to myself, I can't even think straight. The other day, I microwaved a bowl with a fork inside. I'm snapping at my partner all the time. And when I'm not angry, I'm crying. Felix cries a lot. I can't figure out what he needs. I'm beginning to believe he hates me. I am starting to resent the baby. I certainly resent all the moms who can breastfeed with no problems. I don't like seeing anyone. I'm exhausted, but I can't sleep. I am sobbing from inadequacy. I miss my old life. Other moms don't feel this way. what is wrong with me? Maybe Felix would be better off if I was not in his life. As Lydia's story is settling in, I'm going to ask you to consider this, that Lydia, or a pregnant or postpartum mother, and especially a postpartum mother, has all the symptoms of depression and anxiety, plus the inability to take a break, plus thoughts of, how will I do this? Why did I have this baby? Can I make the baby go away? Or do I need to go away? And it is this juxtaposition of one of life's greatest gifts alongside one of life's most unkind illnesses that makes PMADs so different and so cruel. Let's take a minute to differentiate PMADs from postpartum blues. The vast majority of postpartum women do experience baby blues. It's about 4 out of 5 women. It happens usually within either immediately after birth or within the first 3 weeks. And these are symptoms that tend to resolve on their own. And the symptoms tend to come and go. They're something like irritability, weepiness. Sometimes the weepiness is from sadness. Sometimes it's just from tenderness and mood swings. They are not so intense that they interfere with a mom's ability to take care of the baby. And about 15 to 20% of postpartum blues are actually PMADs that are either beginning to express themselves or resemble something like postpartum blues. So if these symptoms are unimproved by 4 weeks after delivery, this mother is likely experiencing a degree of perinatal mood and anxiety disorders. What do PMADs tend to look like? And I am not going to talk about all the presentation of PMADs. I'm just going to focus on depression and anxiety today, which tend to be the more common ones in the PMADs cluster. So how do depressed mothers feel? Depressed mothers can feel sad, but in my experience and in the experience of a lot of my colleagues, in a surprising way, sadness is often actually not the predominant emotion that moms come in with. They are much more commonly agitated, impatient, and dysphoric. They have feelings of unreality, like feelings of disconnection from the way that their life is going about. They feel mournful and full of regret at what has happened to them. They can feel trapped and completely at the mercy of the difficulties that they're facing. They have profound feelings of inadequacy, usually expressed in the form of thoughts of, I'm not enough, I'm not doing enough, which then becomes the perfect entryway to feeling guilty and having extremely low levels of self-worth and self-confidence, especially in their identity as a mother. And they experience quite a lot of feelings of resentment and anger. Common thinking patterns of depressed mothers is that they hold unrealistic expectations, both for themselves as a mother, and this is very much reminiscent of the maternal archetypes that I talked about, that they put that as the benchmark of how they should look, how they should be, how they should function. And they tend to have quite unrealistic expectations for their babies too. In the way that, often I'll hear like, my baby has to be happy all the time, or if my baby's crying, then it means I'm failing him or her. They tend to be they are profoundly negative in the way that they think, especially about themselves and in their capacities as a mother. They have a diminished capacity to think clearly and often describe being in a haze or in some kind of a fog. And they can have scary thoughts, either thoughts of harm coming to themselves or of harm coming to their babies that feel distressing to them, or thoughts about death because that feels like the only option for relief for them. Postpartum anxiety is the other postpartum problem. And this one I find is often under-recognized because anxiety can have many faces, and a lot of the worries are based in reality. So for mild to moderately anxious mothers, they can give off the perception that they're just super responsible and super conscientious mothers. And for a lot of these reasons, postpartum anxiety is relatively understudied, especially in comparison with postpartum depression. But we estimate that it is probably more common than postpartum depression. And PPD and postpartum anxiety go hand in hand. About 50% of women with postpartum depression show a mixed presentation with postpartum anxiety. How do anxious mothers feel? These women, especially the ones who don't have a comorbid postpartum depressive episode, often don't feel at all depressed, just enormously overwhelmed and extremely on edge. One of my patients once walked into my office and she was just so restless and so uneasy. And as soon as she sat down, she said, I don't know what's going on with me, but I feel like I have bees buzzing in my blood. And I find this to be such an accurate representation of a lot of other moms who struggle with just postpartum anxiety. These moms often feel robbed of clarity and peace. They can never feel fully or enduringly reassured, despite objectively reassuring data from their pediatrician, from the baby's development, from family, from friends. Their thinking patterns tend to be quite circular, like they just kind of ruminate and circle around worries that don't lead to any productive outcomes. Their thought structure is based on all the possibilities of scary and fearful things that could happen, not necessarily what is likely to happen. And this type of thinking pattern tends to push them toward living in the extremes of possibilities, towards thinking either a decision is right or wrong, or something is safe or dangerous, no in between. And in turn, as a way to have a certain sense of control, they cling to very rigid standards. Things like, there is a potential for my child suffering from sudden infant death syndrome. So in order for my child to be alive, I have to watch my baby while he sleeps to make sure that he is breathing. In terms of behaviors, both depressed and anxious mothers can have similar behavioral kind of representations, but they can signify different sources. So crying tends to be a common one that's actually shared by both depressed and anxious mothers. In someone who's depressed, this tends to come more from feelings of desperation and defeat. And in the anxious mother, it comes more from feelings of overwhelm. They tend to be stuck in cycles of conflict within themselves and with their partner. They tend to be more withdrawn, either because they're tapped out, more from a depressive process, or because it's the way that they're managing risk. They're just avoiding stuff. They have an inability to take action, either because they're bogged down from having to make the perfect choice and they get stuck, or because they're just exhausted and don't have any more cognitive capacity to be able to make, probably the hundreds of choices each day that comes with taking care of a newborn. They tend to be frantic in their efforts to gain control, and this is often centered around kind of baby and baby care, things like feeding, baby sleep, exposure to illness and germs, the baby's breathing. and they have sleep problems, especially that they seem unable to sleep even when they have the opportunity to. The time course for these presentations is from birth to 1 year postpartum. A mom can be solid in her mood up until month 4, month 6, month 8, and just suddenly start to express some of these symptom clusters, and it is still considered to be a PMAD. But generally speaking, there's some vulnerable time points like the newborn period, the first 4 months postpartum, the time when a mom is returning to work, and when she's weaning from breastfeeding. All of these conditions are highly treatable, but they do not resolve on their own. They do usually need some kind of intervention. PMADs can present after 1 year postpartum, but usually this is because it was some kind of a PMAD that went either undiagnosed or untreated or undertreated in the first year. A very common question I get when moms come to me is this postpartum depression, postpartum anxiety, or is this normal stress? And if you look at the previous list of symptoms that I went over, these are all things that mothers can experience from time to time. And just because a mom has 1 or 2 or maybe even 3 of these on occasion does not necessarily mean that she has a PMAD. So one way that I like to conceptualize the difference is, what is the balance between the hard stuff and between hope and the hopeful parts of becoming a new parent? So here's an example of what I would consider more typical stress in the postpartum period. Despite the exhaustion from sleep deprivation and the constant feeds, this is a mom who can keep the bigger picture in mind. She can access hope that things can get better. She can access tender and warm moments with her child. In really hard moments, she can have a longing for the days when she was more free, but she can still access kind of enjoyable and pleasant feelings, even if they are fleeting. She can take the moments of overwhelm and the hard and contextualize them within a sense of strength and capability. And she can take these moments of overwhelm and situational stress and kind of turn them off to be able to sleep when her baby sleeps. And as a whole, no matter how hard this period is, she still feels like she's picking up skills along the way. And this tends to feed into feelings of, all right, I'm capable. I can do this stuff. And by contrast, someone who's experiencing PMADs, one has way more of the symptomatology tipped towards the hard. It is more extreme and intense in its presentation. And oftentimes, it either silences the sense of hope and capability and strength and joy, or completely eclipses it. And if that's the case, especially over a prolonged period of time, I'm not just talking about a day or two here, but over the course of weeks and especially months, then I tend to lean more towards PMADs. The other piece that I think is really important to keep in mind is negative thinking is over and over again a hallmark of PMADs, that moms tend to take things that are hard and turn it around into a personalized way and make it about either themselves or something being wrong with their baby. And one of the ways I like to kind of illustrate this is that for a mom with typical stress, if her baby was up all night crying nonstop, then she has the thought of, I am exhausted because this is hard, and I'm probably going to feel better when I take a break. By contrast, a mom who is experiencing a PMAD will take the same input, the same situation that her baby cried nonstop all night, but she interprets it in a very different way of reasoning. She says, he's doing this because he hates me, or because I'm inadequate, or I'm failing him, and therefore I'm a burden to this family. And generally, when I hear these thought structures, my alarms for PMADs tend to go off. Okay, let's go back to Lydia and give you a case update. There was a day where I ran into my neighbor grabbing the mail. She was newly postpartum too. Her hair was disheveled, and she was wearing burp-stained pajamas. I genuinely asked her, "How are you doing?" She shared some of the same struggles I was experiencing. I felt less alone for the first time in weeks. In an unexpected way, I even felt some hope that maybe things felt hard because they were hard, not because I was failing. That there could be good moms who felt like me. That day, I decided to make feeding easier on myself. I began giving Felix more formula. He wasn't hungry anymore. He started crossing percentiles. I could sleep through the night without waking up to pump. My partner and I took turns feeding. With both of us better rested, we began to fight less. What we see Lydia arriving at rather intuitively are some of the common strategies for treatment that we use in the field. And I like to break down these treatment strategies into 3 clusters, organized by what is most accessible and most affordable, down to what tends to be less accessible and more costly. Changes at home are the most affordable and the most accessible, but they are not necessarily the easiest to implement. And if there's one thing out of this list that I would highlight, put neon lights around, flash it across billboards, it would be to protect mom's sleep. If mom is able to get solid stretches of sleep, preferably in the amounts of 4 to 5 hours of consolidated, uninterrupted sleep, that can be both preventive for a lot of PMADs, but it can also be diagnostic, because if mom has the opportunity to sleep for those stretches, but she's unable to, then that's a different story. We're talking definitely about a PMAD, and we're probably talking about a higher severity of a PMAD. Moms often forget to eat and to feed themselves because they're so preoccupied with feeding the baby, and especially if the baby is being breastfed, that even when breastfeeding goes well, it tends to be quite a demanding and difficult process. So mom loses sight of her own nutrition often. So making sure that moms are eating nice, if they can eat something that's nutritive, but I tend to prefer they eat anything rather than nothing, and that they are hydrating, especially so if they are nursing mothers. They tend to need higher caloric needs and more water to be able to support breastfeeding. I really like to encourage time alone for moms. And if they can leave the store, go out, leave to the store, leave the house, walk outside, often that is an essential component of being able to preserve the time alone, is to separate from the baby and from the home. That tends to be quite effective. And movement. I deliberately don't call it exercise because it is not about intensity. It is just about mom being able to kind of break out of being strapped down under a baby and sitting in a chair or sitting in a corner. It's just about getting some space in her body, and preferably, if possible, to get the movement outdoors. Peer and family support is another component that is very, very important. Being able to work with a new mom to identify resources for support. And then this part tends to be the catch for a lot of new moms, in being able to receive the help, not just ask for it, but to receive it, which often comes with a certain amount of training of resist the impulse to say no, resist the impulse to say, no, I'm fine, I'm going to be okay. Just be able to say, yes, I would love that. That would be a great help if you could cook some dinner and bring it over for me. There are also some fantastic peer support groups that are facilitated by professionals. Postpartum Support International and Postpartum Support Virginia have virtual ones that are completely free and drop-ins. More locally, for in-person ones, PACE groups PACE has been around for 50 years, and they have fantastic peer support groups. And the Spring Project is another group that offers small groups, like I think groups of 5 or 6 women who can get together at a similar stage in their pregnancy or postpartum journey for support. And then, of course, there's higher levels of care, like being able to engage with a psychotherapist for talk therapy, or with somebody who can offer medication management. And this can be any physician who has interface with mothers. It can be their OB, can be their family physician, and it can be their psychiatrist. How do we decide between therapy or medications? When the choice is available, it's definitely the choice depends on mom's wishes. But there's some other factors too, which is just what is accessible to them and what's available to them, the urgency of what's going on, and the severity of illness. What I found is that perinatal populations overwhelmingly prefer psychological interventions, meaning therapy, over pharmacological ones. And both psychological and pharmacological interventions can be effective and are effective. Both can loosen some of these negative, unhelpful thought patterns and make room for different emotions to come up and different choices for mom in a way that can support her better. For moms who have moderate to severe degrees of PMADs, generally speaking, the intervention is less about therapy or medication, and they tend to require a combined treatment strategy. For mild to more moderate degrees, I find it okay to just start with therapy. But one piece that I keep in mind is pharmacological treatments do tend to lead to quicker symptom remission, on average by about 5.5 months. That if I found when we introduce medications, moms tend to be in a much better place of functioning, if not completely in remission, by about 2 to 3 months. And with therapy alone, it tends to take closer to 5 to 9 months to achieve the same results. I am going to show you a common therapeutic modality from cognitive behavioral therapy that we use both as a psychotherapeutic, like a talk therapy intervention, but also as a way to determine when or if medications can enter the picture. So a mom enters into the picture with feelings of anxiousness. Her anxious mood can be accompanied by fearful thoughts like, is my baby breathing? This kind of thought informs her behavior that rather than she sleep when the baby sleeps, she is consumed with watching the baby breathe while he is sleeping. This in turn causes her potentially to miss, a well child visit with her pediatrician. When she realizes this, she feels absolutely distraught. And then she has those negativistic thought patterns that I'm failing as a mother. Now, one way we can come into this loop is to enter with something called cognitive restructuring, and we'll target a thought that might be living more in the extreme ends and say, rather than constantly worry, is my baby breathing? Can you have an alternative thought like, babies are generally resilient. I am following safe sleep recommendations. That's what my pediatrician said. That is enough. My baby's going to be okay. And then following that, softening of a thought with a behavioral modification so that when the baby sleeps, mom is able to sleep too. Now, if mom really hits some barriers, either with the ability to kind of hold on to some alternative cognitive thought, a cognitive restructure, or with the ability to sleep when the baby sleeps, then often this can be a clue that she may benefit from medication initiation. And once she's able to introduce these changes, then she feels more relaxed. because she sleeps. And when she feels more relaxed, and eventually she begins to reinforce. And if you find that your individual risk factors are quite lengthy, and I would pen that at about maybe, having 2 or 3, then I would really focus on optimizing mental health before delivery, and perhaps establishing with some kind of a mental health professional, whether that's a therapist or a psychiatrist, and I would consider a reproductive psychiatrist if you are on any kind of a psychotropic regimen, alongside your obstetric care during pregnancy. And if somebody is on psychiatric medication, please, please, please seek professional counsel before discontinuing them when you're deciding to enter the family planning stage of your life, or if you are pregnant. Many, many, many medications are actually safer than what we think in pregnancy. And even if they're not, there's often many options available, many more options than what people think is available to them. At some of these macro levels, I like to encourage families to think about the ways that they are participating in cultural individualism, and to try with what is possible for them to practice and adopt values of more community living. And maybe that can be approachable from, beginning with identifying your village and practicing with who you can ask for what, and practicing how to accept help. And of course, if you can join any of those facilitator-led pregnancy and postpartum groups, the free ones, the paid ones, I do think that's going to serve you well. Around motherhood expectations, I think it's really helpful to check in and review kind of how do I think the postpartum period is going to be? What are my expectations of myself? And if you find yourself kind of stacking on these expectations of how you're going to function and how you're going to look and how you're going to perform and what your baby's going to be like, then I would invite you to maybe think through the lens of, all right, I can't have all of these, or I might not be able to have all of these because these are quite idealized representations, but what are some realistic ones that I can take away? And this often falls on what are things that I value in my postpartum journey. And lastly, in terms of the structural failures that we have in our country, there's limitations of what we can do, but there's also not, it's not that we can't do anything. So I like to encourage families to practice quite fierce self-advocacy, both within the home in the way that some of the domestic duties are distributed, at work in advocating for what you may need and what may be available to you that is not fully apparent, at the doctors, if you have a sense that something is not being taken seriously, and then if you have energy and if you have time, at the policy level, so that hopefully we can change some of these systemic inadequacies. Okay. An update from Lydia after she was more engaged with treatment. Becoming a mother leaves no woman as it found her. Motherhood can be both beautiful and brutal, sometimes at the same time. For me, it was like getting thrown into a well. While groping around in that dark foreign land, I found parts of myself that I had feared and had never faced. I eventually learned that the way out was through holding myself with the same care the same love, the same tenderness that I offered Felix. By letting go of what I thought my motherhood journey was supposed to be, I made room for what was and made decisions that supported me in that dark place. These days, Felix is the light that beams from my arms. When I hold him, I feel his body soften into mine, and I, in turn, feel grounded from his trust. We've become two luminous beings who have built a knowing that is unique to the two of us. Matrescence is a word that describes the process of becoming a mother. Motherhood in our culture means to nurture another. To this end, many new moms learn, painfully, that fulfilling motherhood in this way ends up erasing them in their role. When a mother becomes invisible to herself, many times at the expense of her own health, it's less about what the child needs and more about her fulfilling her new identity. And giving birth to a new identity can be as demanding as giving birth to a baby. What I propose to you today is to consider an alternative entry into matrescence, one that carries an edited and kinder version of motherhood, where being a mother means to nurture a new life while also nurturing a new self. I'm going to leave you with a beautiful poem by Kate Baer. I dreamt myself into a mother, but when I became her, I had to dream her back into a woman, back into a woman, back into a woman again. I thank you for your attention today. If you would like to get in touch with me, this is my information. I want to give a plug for Dr. Schauberi for kindly agreeing to share his artwork, which just completed this presentation in the most wonderful of ways. The closing show for the exhibit is this weekend, and if you're able to attend, I would highly, highly, highly attend it. It's at the DuPont Underground Gallery. I have a list of resources, both in terms of peer groups, databases that include kind of a list of professionals for therapy, for psychiatry. There are hotlines available through Postpartum Support International, through Postpartum Support Virginia, and through international national maternal mental health hotlines. And then Postpartum Support Virginia is really a tremendous resource for us. So if there's one place to start, that's the place that I would recommend. And with that, we come to the end of this talk. Okay.
Yasmin, thank you so much. That was absolutely amazing. And for those of you who, there's a lot of information that came through at the end, and we'll make sure to include all of that on our show notes so that when you do go back to watch this again, or when you tell other people about this so that they can watch it again, that all that information will be on there in terms of the information, especially the support groups. So I just really felt like, going through everything that you presented, I felt like I was going through Dr. Schauberi's exhibit, because I really feel what he presented was, is sort of the grief process, the kind of going through the different stages. And, I felt like I kind of followed along, and especially at the very end, there was a very beautiful tribute to the healing process of, finding yourself again and healing and finding, the womanhood again. Quickly, one thing that you had mentioned is that one of the risks for postpartum depression is pain and physical trauma. And, I was going to just kind of point this towards Dr. Schauberi, because you actually see women who have actually gone through a pain and, physical trauma as a result of their childbirth. So, could you just speak a little bit to some of the women that you've seen and especially presenting to you in these states?
I think what we try to get across people is that since nobody really knows what the delivery is supposed to be like, is their first baby, and when there is physical trauma to the pelvic floor, they really think that's part of a normal vaginal delivery or process. So I encourage people that if there's symptoms of discomfort, whatever it may be, inability to void, defecation issues, pressure while they're standing, so on and so forth, they really need to seek care. And unfortunately, this is very specialized care that they need to seek, because the pelvic floor muscles cannot be seen visibly. So they have to see a urogynecologist who has capability to do imaging, either MRI or 3D ultrasound, to look at their pelvic floor muscles. Most people are very focused on visible injury to the vaginal area and perineal area, but the invisible injury that is in the pelvic floor gets missed. And consequently, what happens is that patients are living with these symptoms of physical trauma, and they go to the physicians and they say they are not feeling well, and they basically don't have a physical diagnosis. So their PTSD literally continues because they are not validated for their symptoms.
Thank you very much for that. It's appreciate the insight into that, and just symptoms that aren't always visible are very hard to treat. And as a primary care doctor, a lot of times it's really hard. Patients even come to us with symptoms of pain, and we can't always find a real reason for that, but it's there, and it impacts the way they feel about themselves. So, and quickly, Dr. Banaei, I know that as a primary care doctor, I do see a lot of patients, even postpartum. I always try to screen for postpartum depression or mood disorders. How do patients find their way to you? Are they referred to you mostly, or do they find you on their own? And what have they tried before actually, reaching a psychiatrist?
Yeah. I get most of my referrals from therapists in the perinatal community. I get a fair amount of referrals from these databases like Postpartum Support International, Postpartum Support Virginia, and in the DC metro area, we have the DC Metro Perinatal Collaborative, which includes a list of vetted therapists, psychiatrists, but they also have really fantastic other resources like for doulas and sleep training and breastfeeding and all the pieces that go into the postpartum period. But we get a fair number through them. Sometimes I get referrals directly from OBs and family physicians, and usually the stage at which they enter to me, they have if they're coming referred through a therapist, they've tried therapy, the therapist has hit a wall or is concerned with the severity of the symptomatology that's presenting. And so they're referring them to me to consider medications. And then sometimes I get something in between, like someone either has a therapist or finds me on their own, and they check in with an OB or with a family physician, and they get started on one of the common medications that, in the class of SSRIs that treat depression and anxiety. And then they come to me and we kind of, pick up where they started. But most commonly, what is a diagnosis? What is the severity level? What are some interventions? And it's not always just medications. As I'm talking to people, I'm looking at these other dimensions because my preference is also to maximize non-pharmacological interventions, in part because the meds can only go so far without some of these other pieces in place, but in part because having those other pieces in place can also reduce the pharmacological burden for them.
Yeah, that makes a lot of sense. And just, I mean, I think being able to, point these women in, towards places of support too, I think is really, really important as well. And some people just may not know about the options out there. So anyway, well, I feel like I could keep talking to you, but I suppose it's 8:03, so I suppose we should probably wrap this up. But I want to thank you, Dr. Banaei and Dr. Shaberi, both for being here. And Dr. Banaei, the presentation you gave was absolutely phenomenal. I'm planning to rewatch this over and over again and make sure that my patients, or anybody that they know who is struggling with postpartum mood disorders, that they watch this. And that goes for everybody, just, keeping this in mind for women that, who, this is just something to, pay close attention to and make sure that you can be that support for that person, you mentioned community, reach out and, be part of the village to help people. So anyway, well, thank you so much for being with us this evening. Again, this is Dr. Cecily Havert signing off, another Northern Virginia Family Practice Town Hall. We'll see you next time.
Thank you for having me. It was a pleasure. Bye.
Thank you.
Good night.